from finance, from health, and civil society to unpack how the G20's Joint Finance Health Task Force and the Pandemic Fund can drive sustainable health investment. The well-being of all, including women, children, adolescents, as a foundation for sustainable development. And this recognition marks a significant step forward in embedding women's and children's and adolescents' health at the heart of the global economic agenda. So today's session, ladies and gentlemen, will turn the same level of ambition and pragmatism towards sexual and productive health within universal health coverage. We meet at a critical inflection point today. Development assistance for health is declining, fiscal space is tightening, and yet demand for services, particularly for women, children, and adolescents, continues to grow. The question is not whether we value sexual and productive health. The question is whether our financing systems and benefit packages indeed reflect the value in concrete, sustainable ways. So over the next 2 hours, we will hear from speakers across the world who will tackle complex but very practical questions on how to integrate high-impact sexual and reproductive health services into explicit universal health coverage benefit packages, on how to design financing models, such as large pooled or single payer arrangements with cross-subsidization that protect access to those least able to pay. We'll also hear topics on how to secure reliable, affordable supplies of essential sexual reproductive health commodities through pooled procurement and strengthened supply chain. We'll also hear about how to monitor and track SRH financing and coverage so that commitments that are made translate into equitable access on the ground. So with that background, and with sincere thanks to all of you for making the time to join this very important conversation and to our partners for their collaboration, I look forward to a rich and solutions-focused discussion this afternoon. But before we move to our first presentation, we'd like to get a quick sense of how this audience is thinking about sexual and reproductive health within universal health coverage and domestic resource mobilization. So now we will turn to technology. We will launch a short Mentimeter poll. Please use the QR code on your screen, scan the code with your phone and click on the link that's been provided. If you go to the chat, you'll see the link is provided. So let's get onto the Mentimeter poll where we'll answer the following question. So the first question for the Mentimeter poll, which will approximately be about 3 minutes, is as follows. When you hear domestically financed sexual and reproductive health within universal health coverage, what comes to mind? When you hear domestically financed and sexual reproductive health within universal health coverage, what comes to mind? Please take 30 seconds to respond to the question, and your inputs will help us understand where we're starting from. Also help our speakers integrate your thoughts and your insights into their presentations. You've got 2 minutes left. Okay, so we're seeing partnerships, we're seeing sustainability, we're seeing equity, collaboration, government-led, accessibility. Great stuff. Super, there we have it. So we've got quite a few themes that are coming through in the word cloud. And I know that our speakers are taking notes so they can integrate some of these themes into their presentation. Great stuff. Colleagues, thank you very much for taking part in the poll. We'll be using Mentimeter as we go, so we can get instant feedback from yourselves. The ideas that you've highlighted will really help anchor this conversation today. It'll guide how we explore policy. It'll influence our thinking around financing, as well as some of the implementation questions before us. Great, and just remember that we'll have a Q&A at the end, and the session will also close with some closing remarks and then next steps for future conversations, right? Okay, I'd like to now transition to the second segment of this afternoon, and that is a segment where we'll get a feature presentation by Jyoti Shankar Tiwari, who joined us from the UNFPA, and the presentation will be approximately 10 minutes long. Just by introduction, to deepen this framing, I'm pleased to introduce Jyoti Shankar Tiwari. Jyoti serves as coordinator of the Integrated Sexual and Reproductive Health Team and Regional Health Systems Advisor for East and Southern Africa at UNFPA, bringing extensive experience at the interface of SRH, health systems, and financing reform. Jyoti, may I invite you to help us understand why sexual and reproductive health must be explicitly embedded within UHC forums, particularly in the context of fiscal constraint and competing policy priorities, please. Over to you, Jyoti.
Thanks, Professor Alistair, and also a big thank you to each one of you for joining this conversation. Initially, when I had the discussion with the GLN organizer, we are expecting around 50 to 60 people. It shows the interest. It looks like we have more than 250 people in this conversation. I hope I'm able to do justice to your time during these 10 minutes. So very briefly, I'm going to share kind of the experience for Eastern Southern African countries, the support which UNFPA in partnership with WHO, UNICEF, UN AIDS, and PMNCH is providing to various country-led processes to situate SRHR within the broader USC conversation, including in USC benefit packages of financing and financial risk protection arrangements, which many countries are in the process of developing new or strengthening the existing one. So before we share the before we go into sharing the 3 key takeaways, can you hear me? Hello?
Yes, we can hear you.
Okay, and you can see my presentation also. Now it's in full screen. Yeah, before we go into talking about our experiences and particularly 3 lessons or takeaways, working with around 10 countries in the last 3 to 4 years, let's have a quick recap of what we mean by USC in practice and comprehensive SRHR in practice. So very broadly, USC means people should get the health services they require without suffering financial hardship. By itself, you can see it's a hugely ambitious goal. Therefore, in practice, it becomes a journey. Depending on your financial situation, the level of development, we start with essential benefit packages. And as the country progresses and develops, the more financing funding becomes available, you expand it. So USC remains a journey for progressively attaining or achieving. People should be getting the health services they require without financial hardship. So the first thing, as you all know, countries have multiple publicly funded or supported service benefit packages. So it's not one, and all of them, they contribute towards the ambition of USC. Similarly, countries have multiple financing arrangement, risk pooling arrangement for providing support. And also, most countries are aspiring to increase the number of services covered under those when additional financing becomes available. So that's kind of our USC ambition. Comprehensive SRHR, the definition of comprehensive SRH and RR has been evolving and changing over time. At this stage, it looks like the global health community agrees these 9 bundles of services should be provided to everyone who needs it through human rights-based approaches across the life course by leaving no one behind, and in both developmental and humanitarian settings. The challenge here, the 9 bundles of services, within each one of them, there are around 40 to 50 services. So we're looking about around 400 services as listed in the WHO compendium, USC compendium. So now it's a challenge in practice. So how do you take and how do you progressively include the 9 bundles of services in the ongoing USC conversations? And we will hear many experiences from many countries. Just before you go into the lessons or takeaways, just to recognize that both universal SRHR as well as the USC are very much part and parcel of our global ambition. Now, having said that, let's look at the takeaway 1. So the first takeaway is the conversation or the realization, which is absolutely evident, that no country will achieve USC without achieving universal access to SRHR. Simple reason that almost 1/3 of the disease burden in Africa among women of reproductive age group comes from inadequate SRH care. So therefore, if you avoid or we don't include SRH in our USC benefit packages and financing arrangement, you're almost neglecting large segment of your population, particularly women and young girls. So therefore, the progress towards USC will never be achieved. And then again, those 9 bundles of services, as I speak, within them, there are 40 to 50 services, as I said. But the diagram there, the Venn diagram there with those 4 circles, that's kind of our intervention spaces or intervention domain. As I said, we have multiple benefit packages, and then we have our comprehensive SRHR services in yellow. Many of the services, SRHR services, are part and parcel already of the essential benefit packages. However, in many places, they probably are not reflected in USC benefit packages. Similarly, even if they are part of the essential package of health services, maybe there is no explicit funding or financing arrangement around them. So you can see where that's the space currently. If you do all the analysis of all the policy and financing and delivery arrangement which exist, probably that's a simplified diagram of what's going on at this stage. Moving on, the takeaway 2, obviously a lot needs to be done to include SRHR in publicly funded or supported health service benefit package. The first thing is that Even if these packages exist, in many of the packages, the way they are defined, there is a huge need to get them better articulated. For example, if you say family planning services are included, does it mean all family planning services are included? Or some family planning services are included? Does it mean emergency contraceptive pill is included? That's a very simplistic example. But in many of our packages, the description of what's included and what's not included needs to be revisited from the SRHR perspective by looking at the USA compendium, which is there, produced by WHO and many other agencies. Similarly, out of the 9 bundle of services, the services which require special attention are: one, the CSE, the Comprehensive Sexuality Education, and its linkage to services. It looks like in many of our countries, the CSE stream and the services stream, they don't talk to each other. And there is a huge amount of work that could be done linking these two streams. Similarly, safe legal abortion, obviously to the full extent of the national laws, and post-abortion care, often missing from these service benefit packages. Health sector response to GBV, not explicitly mentioned in many countries. Similarly, FGM, child marriage, the health sector response to these harmful practices again are missing. Menstrual health, hardly you will find in any essential benefit package or service benefit package. Reproductive cancers, they are there in various degree. So fertility, infertility, again another area which needs attention. And even if the other 3 services, the primary, the health services, maternal health, family planning, HIV, which are included, it's not comprehensive enough. As I said, it's not described in a way that one will be able to assess what's in and what's out. So even if the things which are there, we need to do a bit of more work there. Similarly, as I pointed out, if you remember the Venn diagram, so there is also a disjoint, maybe the coherence between the USC benefit packages and the financing arrangement and what's covered under the NHI and other state-funded financial health protection systems needs to be improved. Similarly, there is a need also to look at the essential medicine list and then look at some of these packages, what they are promising, whether those essential medicines are part of those list. Again, each of these areas of work could be taken on by many partners and agencies. And then the whole idea of the USC through ESC conversation, even if many countries has agreed on this, it looks like many of my USC benefit packages probably give a bit of more attention to secondary and tertiary care over the primary care. And everybody knows special attention needs to be paid to refugees, unmarried adolescents, survivors of GBV and harmful practices, not explicitly mentioned in most benefit packages. Very quickly, that's my third and last takeaway. So the diagram which you see on your left is the current situation. So the country-led processes with support from us and many other partners are trying to move towards the diagram which is on your right, so that SRHR services progressively become part and parcel of the USC benefit packages, and everything was listed under the USC benefit packages have some kind of a sustainable financing arrangement and financial protection arrangement around them. And obviously, we still have this highly aspirational essential package of health services. And then currently, if you kind of count or cost the essential package of health services in most countries, it is huge. You almost need to spend maybe 30 to 35% of your budget just financing the essential primary healthcare packages. So that's kind of great to have that ambitious one, but the idea is to how can you progressively prioritize, and in the prioritization, prioritize the needs of women and girls. So with that, I guess these are some examples, but I'm not going to go through this. But at the end, let me stop with this. Why is it so important? Why should we be bothering about including SRHR within USC? And then what does USC does to a girl or a woman? Just an example here, which UNFPA and other partners have been working for everything which is listed there. Huge amount of evidence has been generated in the last 30 years. Without SRHR services, we are looking at a pathway, the red pathway of child marriage, leaving school, teen and repeat pregnancy, high maternal and neonatal mortality, informal work insecurity, and missed human potential, demographic and multiple dividend, whether it's gender dividend, health dividend, economic dividend, or climate dividend. Similarly, with a comprehensive SRHR, you are looking at a pathway or in school, good health and well-being, decent employment, adult marriage, healthy motherhood, security of place and wealth and investment leading to multiple dividend and human potential. And everything what we spoke, the 9 bundle of services, basically bridges these two pathways, takes a girl from the red pathway to the green pathway. And therefore, the inclusion of SRHR in USC is so critical and for development, and it's a developmental imperative. And everybody spoke about it during our multi-meter poll. The simple fact also remains the same. If you can't bring in more money for SRHR within the current fiscal space and budgetary mechanism, take SRHR where the money is. And it looks like currently a lot of countries are trying to figure out resources around USC benefit packages and how those could be funded. So for us, it's really difficult at this current environment to bring in new money to health sector in many, many countries. So probably we don't have a choice. We need to take SRHR where the money is. Over to you, Professor Alistair.
Thank you very much, Yoti. Yoti joins us from Eritrea. Thank you for that very clear and thought-provoking framing, Yoti. We really appreciate it. So we're now going to change gears and shift our focus from the global and regional perspectives are playing out at a country level. And we'll hear what SRH within UHC looks like in practice. So for our third segment, I'd like to invite the next speaker who joins us from Zambia Medicines and Medical Supplies Agencies, and that's Rachel Msimuko. Zambia's recent experience offers important lessons on how to protect access to SRH services while strengthening national systems under fiscal pressure. I'm honored to invite Ms. Rachel Msimuku, Acting Director of the Zambia Medicines and Medical Supplies Agency, to offer our first country perspective. Ms. Msimuku, could you share what Zambia has learned about safeguarding SRH access through UHC mechanisms, particularly when it relates to securing supply chains, reliable access to essential medicines, and the use of pooled procurement or other financing arrangements to sustain these gains, please? Ms. Rachel, over to you.
Thank you, Professor, and thank you to everyone who's participating in this webinar. It is really an honor for me to be part of this very important conversation on SRH commodity security for universal health coverage and just sharing our Zambia country experience. So our context, and for the Zambian context, we have been making some strides, really working hard to improve sexual and reproductive health commodity security. The previous speaker talked about all the different aspects of sexual and reproductive health and the different services, the multiple services. And what is clear is that without commodity security, it's not possible to achieve the intended health outcomes in any of the 9 spaces and the myriad of services that were described by the previous speaker. And so what Zambia has been doing is just looking at how do we invest in sexual and reproductive health by ensuring commodity security. And the country has been progressively increasing the budget allocations for medicines and medical supplies. it's in 2026, our budget increased to about $365 million US. In Zambian kwacha, that's like 7.3 billion kwacha. And that was an increase from 5.6 billion kwacha in 2025. This is for the general procurement of medicines and medical supplies, including medical equipment that are used in these health facilities to serve mothers and children. And then also part of what government has been doing is just also ensuring there's a budget allocation that is targeted towards distribution of medicines and medical supplies to the last mile, so that people are able to receive the supplies when they need them. And also inclusion. There's been a lot of progress and advocacy, and which has resulted in the inclusion of SRH commodities in the NEMA, in the National Health Insurance System benefit package. All this investment has been good in terms of reducing the stock-out rate. This is the central level stock-out rate. That is at the Zambia Medicines and Medical Supplies Agency, which is what responds to the public health sector. In Zambia, people access health services from our public health facilities free of charge. So government invests, and as an agency, we procure, store, and distribute. And at the health facilities, these services are offered free to the patient. So at central level, we achieved a stock-out rate of 20%, while regionally, it's around 35%. Of course, efforts are ongoing to ensure that we reduce this stock-out rate further so that we can ensure commodity security. Another achievement in Zambia has been the reduction in the maternal mortality ratio, which has reduced from 252 to 187 in 2024. Of course, we're heading towards the SDG targets. And of course, there's a lot of work that needs to be done, but progressively we are doing what we can to reduce the maternal mortality ratio. Just wanted to give an illustration of the domestic financing in country. So what the government has done in Zambia is to provide a dedicated budget line for reproductive health commodities. And this dedicated budget line has been growing year on year. And in 2023, government put in 2.7 million US dollars, and then in 2024, 4.4, and 2025, 4.3, and has allocated 7.8 million US dollars to this year's procurement of reproductive health commodities. This has been also in tandem with the compact agreement that we have with UNFPA, where there has been match fund incentives, even as there has been increased domestic financing. So those the match fund has been able to fill in gaps where we've had gaps, and this we were able to apply and get a match fund of $1.5 million in 2023 and $2 million in 2024 and 2025. This year, the allocation is smaller, and this is talking to sustainability, where you see government putting in more and then partners putting in less. So part of our story as Zambia is just the encouraging of strategic partnerships, the UNFPA compact agreement that I spoke of in the previous slide, which had match fund incentives for increased domestic investment, and then to ensure that the products that are coming in are quality assured. We've also engaged in MOUs. Those are third-party procurement mechanisms. So we have MOUs with UN agencies, the Global Fund, where we are able to use government funds, but through their systems to be able to access quality assured products. And we also have several partners that we still continue to work with. But what I just wanted to emphasize here, even as we highlight this very much appreciated technical and financial support that we receive, is that this technical assistance and the support in system strengthening are now more focused on sustainability. How can whatever improvements we're doing be sustained even when the landscape changes. So these have been in procurement. We've also received support in procurement of commodities where other partners procure and bring into our supply chain, as well as last mile distribution and private sector collaborations. In terms of strengthening supply chain systems so that we assure commodity security, before we procure, we need to know what we need to bring in. So we do national quantification exercises with multi-stakeholder participation, partners, actual frontline people who speak into the quantification process, as well as improving the information systems that we're using for reporting and monitoring, and integrating also the new maternal health commodities that are coming on board that are securing the lives of our mothers, that have scientific evidence that we can put in. And then also coordinating across different structures in terms of technical working groups, such as the supply chain technical working group, family planning technical working group, and safe motherhood technical working groups. In all of this, even with these successes, we have had challenges, and I think all the countries have experienced this abrupt change in donor funding landscape as happened in 2025. And this caused pipeline disorientation where partner committed goods were not able to come in good time, data system disruption where data systems were being supported by partners, human resource gaps where actual health workers were supported by partners, as well as delayed distributions. So what we're doing about this is just ensuring that as much as possible, we keep increasing our domestic financing and ensuring that the critical areas are government-led. Of course, global supply disruptions remain a risk in any supply chain. And I think the last few days have shown the world that we cannot predict the stability of certain regions, even in terms of being able to pass commodities through them. So we always have to be prepared and understand that we need to diversify the sources where supplies are coming from, so that even if a region is impacted, you still have diversified sources, and also ensuring that for manufacturing, we bring a lot of it home here in Africa so that we are more secure in that instance. And I've also just highlighted some of the different challenges as well. But I wanted to also highlight out of these different challenges that we've been facing and the different solutions that we have, and in the move towards sustainability, the collaborations in the region are providing a template of what we can do to have sustainability. So Zambia is participating in the SADC Food Procurement Initiative under the SADC Food Procurement Services, SPPS. And what the collaboration is supposed to do in terms of securing commodity securities, allowing the countries to access quality assured medicines and health by bringing together the demand from the different countries and having collective bargaining power so that we can reduce prices and secure access. And also this improves supply chain resilience because we're able to source and see the market, and also
Apologies, we seem to have lost Rachel. Over to you, Professor Alistair.
Rachel, can you hear us? Rachel? Okay, we seem to be having connectivity issues with Zambia. Thank you very much for that rich presentation, Rachel. Lots of insights there and quite instructive in how Zambia is dealing with these issues. We're going to press on to segment number 4, which takes us out of a country perspective into a perspective outside the continent, specifically China. This next segment is a presentation by from Fudan University and WHO Collaborating Center. It is a pleasure to invite Professor Ying Chen. He's a professor of health technology assessment at the Fudan University School of Public Health and director of WHO Collaborating Center for Health Technology Assessment in Shanghai. In fact, as the Joburg Business School, we had the pleasure of hosting a delegation from Fudan recently. Professor Chen, can I ask you to reflect on how strategic purchasing and the use of data systems can strengthen the integration of maternal and reproductive health systems within UHC benefit design, particularly in terms of prioritization, provider payment, as well as monitoring equity? Over to you, Prof. Chen.
Okay, thank you, moderator. Can you hear me and see the screen? Part is, I think, is mainly those health insurance. So those and the words in the dark blue, and that's means that China, we have the medical insurance coverage, and also including the catastrophic and the illness insurance, but also including long-term care, and also the other the activity, including the volume-based procurement of the a generic drug. So that's in China, we call that's the VBP, and the value-based purchasing, I think is very important, and cutting all those kind of medical drugs and also devices, and the price is quite reasonable. And there also the other thing is for those kind of innovative and drugs, and we also use HTA, health technology assessment, or pharmacoeconomic and strategy, and do those kind of strategic purchasing for those innovative and drugs. And the other is like in the purple, and mainly for those maternal and child health services, mainly a lot of maternal and child and those kind of program or projects. And for example, some is for the tuberculosis, and some for the those kind of HIV, syphilis, and hepatitis B, and the other and the cervical cancer. So I think in this area we have a lot of maternal and child projects, and also and try to achieving the UHC. The other very important component in China is just strengthening the maternal and child health services system. So that's actually is from provider side, and improving those provider capacity, including OB, obstetrics and gynecology, and also pediatric resources. So that's, I think, the health services and system in China. And in the middle is the maternal and child health hospital at national level, provincial level, municipal level, and the other two parts is urban area and rural area, not just those and specific and specialty, those healthcare services, but also have the grassroots and their facility. For example, in the urban, we have the district maternal and child health institution for MHC and those services, but also have the community health center and just provide those services to the neighborhood. But we also have the station just in the different and neighborhood. And in the rural area, we also have those kind of counterpart and county level institution, township and health center, but also the village doctor and in the village. So I think that's very important for China, how just provide those services and by such kind of independent maternal and child health services system. And then we have different services and also with the multi-funding sources. So here I think one is the maternal and child health services package, and that's under the National Basic Public Health Services package. Those and the money actually is just provided by the that's Ministry of Finance, and that's just try to achieve the equalization and for those kind of the recipients. And that's mainly from the central government of finance and also provincial and the government and subsidized. Then and beyond that is the basic maternal and child health medical services. So that's a reasonable shaping by government and the society and the individual, mainly by the medical insurance and covers those kind of basic and maternal and child health medical services. And the other one is maternal and child health specialties medical services. That's the medical insurance, but also including individual or commercial and those insurance. And that's and actually is a multi and model and investment approach, and that's one is a financial investment at all levels continues to increase. The total amount of the financial subsidy has growing substantially, especially for the maternal and the child health services. The other one is enhanced insurance coverage for major diseases, improve the services coverage, and also reducing out-of-pocket by strategic purchasing, mainly use the HTA and also poor procurement. I will present a little bit about how use HTA and select those kind of cost effectiveness drugs and medical devices and into the medical insurance and reimbursement list. But also for the poor procurement, and that's and actually is just reducing the price of drug and medical devices is significant. So especially for those kind of already have a lot of competition and in the drug and the area or medical devices. So that's and make the price and quite low and also assurance of quality. So I think that's a very important measure for China and provide a quality and services for those kind of maternal and child population. And the other one is the key maternal and child health project or program, some are included in the routine basic public health services. And the other is a kind of a project, for example, cervical cancer project, breast cancer projects, and the children's congenital heart disease and the prevention and the treatment and the program. So that's, I think, from the just project and the site, and then have some accumulated experiences, and then and just try to scale up and to the bigger, that's the scales. So this is just slideshow how HTA utilization in different stage of life cycle by technology. And I just highlighted the reimbursement and benefit package coverage mainly is responsible by the National Medical Insurance Authority for those pharmaceuticals and using the economic evaluation. That's the model and just the dossier and application, and also the dossier critical, that's the review and the critiques, and that's the appraisal, and so cutting those innovative and that's the drugs and the price, but also do the budget impact analysis, look at the impact for the medical insurance fund and how to just save the money from the medical insurance fund. So that's mainly for the medical device, pharmaceuticals, and not too much on the medical devices. And for the maternal and child health and services and pharmacoeconomics, and basically use those kind of cost effectiveness analysis and to select those kind of appropriate and maternal and child services. So in this slide show different technology type, and I think for the NHC, that's the Ministry of Health. The other one is National Medical Insurance Authority. You can look at 3+ means and the cost effectiveness mainly for the pharmaceutical, but not too much on the medical devices, clinical procedure or screening. We use a little bit in the cost effectiveness analysis, and but not in the significant. I think, and we should improve those kind of using cost effectiveness, informing the policy making, and for those kind of services inclusion. So the other one, and talk about those kind of maternal and child and the project. So here is that's the elimination of cervical cancer. So that's we provide a lot big and a number for the cervical cancer screening and conducted and nationwide. And we also have the national, that's the action and for the elimination of cervical cancer. And we have a lot of strategy, including screening, including vaccination, and also those kind of multi-sector collaboration, and also comprehensive measures and targeting both the supply and the demand side. So that's kind of use the comprehensive and cervical cancer elimination and intervention and try to achieve the target. So that's the one case for the cervical cancer screening. But we also have the other one that's for the birth defects and prevention and control. So those are all the different indicator and show and how we just control the birth defects and mainly including congenital heart diseases and also Down syndrome and the newborn screening and others. And I think that's also a very good and the strategy and try to improve those maternal and child health outcomes. The other projects are mainly for those children's health. And here you can see a serious technical and their specification.
Can you hear us, Prof. Chen? No audio from Prof. Chen? Okay. Well, that's a summary slide. So I think Prof. Chen was at the end of his presentation. Thank you for sharing those great insights on data-driven purchasing, Prof. Chen. Thank you for sharing your insights around quality and equity monitoring. And of course, we heard quite a bit about the role of HTA in privatization. So great perspective coming out of China. And we thank you very much for those insights. So we've set a really nice foundation, both from a global perspective as well as a regional and in-country perspective. And what I'd like to do now is turn our focus to the panel that we've got for today. We've got a fantastic panel of 5 panelists, and that'll be a 30-minute discussion. And the panelists are as follows. We'll start with Dr. Katleho Mutudi. Dr. Katleho Mutudi is the Managing Director of the Board of Healthcare Funders, BHF, in Southern Africa. The second panelist is Ola Bukunola Williams, and representing Sexual and Reproductive Health and Rights Lead for Akina Mamawa Africa. The third panelist is Dr. Zainab Esak. She's a Research Director with the Human Sciences Research Council in South Africa. And then we've got Ms. Rachel Msimuko, who we just heard from now, Acting Director of Zambia Medicines and Medical Supplies Agency, ZAMSA. And the last panelist who we just had the benefit of listening to is Professor Yingyao Chen from Shanghai, from Fudan University. He's a professor of health technology assessment at Fudan University School of Public Health and a director of WHO Collaborating Center for Health Technology Assessment in Shanghai. So that's our panel for this afternoon. Each panelist will have about 4 or 5 minutes to just to address us. And then at the end of the panel discussions, we'll have a Q&A where all of us will be able to ask questions. So Dr. Katleho Mutudi, let's start with you. Your question for today is, many countries continue to operate fragmented health financing schemes, which can limit equitable access to SRHR services. From the perspective of health insurers and strategic purchasers, how can national health insurance systems be designed to strengthen risk pooling and cross-subsidization, particularly to protect women, children, and adolescents, while also leveraging single-payer or pooled purchasing approaches to achieve economies of scale and reduce the cost of essential SRH commodities and services within universal health coverage. So that's the question for you, Dr. Mutudi. You've got 5 minutes to address us on this question. Over to you.
Yeah, thank you very much, and good afternoon, Prof. Good to see you again, and thanks for the invitation. I think most people, when they think about the role of the private sector, especially in the context of South Africa, the term two-tier system becomes prominent in the thinking, and that is central to the challenge around how to harmonize services, not just restricted to sexual and reproductive health. So the first thing really is to find a nexus for policy coherence, because often the rules are designed differently for the public sector and for the private sector, although the intention is or should be the same. And I'll give an example. For medical schemes in South Africa, we have what we call prescribed minimum benefits, which are a schedule of benefits which the schemes have to provide cover for. Because of the costs of healthcare services, you often find that the bulk of the cash injection goes towards this, and very little goes towards what would then tend to be primary care services. For a long time, for example, contraceptives were not covered by schemes because they were classified, they were not classified as prescribed minimum benefits. And that was counterintuitive, because if you do not prevent unplanned for incidents or pregnancies, you end up having to fund, for example, termination of pregnancy. So that is the first area, even before you consider funding. I think the second area that we need to focus on is that when we talk about risk pooling, it does not necessarily imply you have to have single funding. There are innovative ways that many other countries, whether you're looking at Germany or Canada, etc., where you were able to find congruence in terms of having a single fund that applies the same standards, but you've got multiple sources of income. And I think the challenge has always been that you'd want to tie down services that are listed as provided for by an institution to the money that flows from that institution. And it doesn't have to be that way. There is a concept that we toyed around with in the mid-2000s in South Africa, Risk Equalization Fund, and that was meant to level the playing fields in terms of the various schemes and their beneficiaries who do not have the same disease burden, etc., but to make sure that those who have got a higher risk exposure can then get money back from the pool, and then be able to attract whatever risk they could afford to have on their books. That is something that was not quite implemented, but I think it's something that can be looked at. While you're looking at taxation as the major funding for government, other entities, be they from the private sector or the donor side, could actually contribute to the fund while certain standards for healthcare are set. Specifically to sexual and reproductive health, you could then prioritize those specific services that are for women, children, and adolescents to make sure that there's always protection for these particular services, and they could actually be prioritized. When you run systems like that, you're not only looking at the cost or the payment side, you must also consider what is happening on the procurement side. if you're running such a pooled system, you are then able to then negotiate on procurement. You do pooled procurement, etc. Prof was talking about strategic purchasing. That goes to how you acquire the services. But also in terms of reinvestments, you are then also able to tailor make reinvestment mechanisms that are tied to outcomes. And with that, you are able then to control costs. I think the discussion when it started and even the theme to this discussion was speaking about protecting rights and making sure that you ensure equity. A lot of us, even in South Africa, for example, are already spending what is recommended by the WHO in terms of GDP allocation of health, but we are nowhere near where we need to be in terms of access. And now looking at all these strategies, we can come closer to making sure that we spend money in the right manner and get the correct outcomes that we seek. Let me pause there, Prof.
Put there, we really appreciate the insights. Just a reminder to the audience, as the various panelists share their perspectives, just jot down any questions you might have for our Q&A just now. The next panelist is Dr. Zainab Essach. Dr. Essach, here's your question. Despite strong evidence of the health and economic benefits of sexual and reproductive health and rights, progress in fully integrating these services into UHC reforms remains uneven. From your perspective, what political and economic arguments are most compelling for governments to prioritize comprehensive SRHR as a core pillar of UHC implementation? You have 5 minutes.
Thank you very much for that question, and it's really good to be here. Hi to all the viewers and those in the audience. I think this is such an important question and just an important discussion overall. It's timely given all the pressures we've had on global health financing and also the risks that progress in women's, children's, and adolescents' health could stall if sexual and reproductive health is not protected within universal health coverage reforms. So to the question, from a policy perspective, governments need to prioritize issues that are based on evidence, but it's rarely the case that it's evidence alone. So from my experience, progress tends to happen when 3 things align. And I'll talk briefly to those 3 things. The first is a strong economic case. And my experience from W20 or Women's 20, which is part of the G20, really underscored the need for cost effectiveness. And we've seen that come through a bit in some of the conversations this afternoon. We've also heard earlier about the importance of alignment with national priorities or government priorities, and my argument will resonate with it. And also importantly is the need for sustained advocacy. So first, in terms of the case of the economic argument that's often the most persuasive for governments. Investments in women's health and also in sexual and reproductive health services are among the most cost-effective of health interventions. And these contribute not only to reductions in maternal mortality, but they also contribute to healthier populations and to stronger economies by enabling women to fully participate in education and also in the workforce. And we saw that in the earlier presentation where there was that red line in a nice visual that aligns well with this statement. My second thing that will reinforce that pillar is that sexual and reproductive health services need to align directly with national priorities. And some of these have been described, like reducing maternal mortality, addressing HIV, improving adolescent health, and strengthening primary healthcare systems more broadly. And then my final element, I think, that becomes important for getting services into universal healthcare systems is the idea of sustained advocacy and building and coalition building, which are essential. Many issues that are now widely recognized within health systems have required years and years of advocacy before they've gained any kind of political traction. And in South Africa, we can use the example of gender-based violence. We've had feminist movements, we've had researchers, many of us have been changing our profile pictures as purple, and many civil society organizations have worked for many, many years to push for recognition of GBV as a public health issue. And this all happened before it was integrated into policy frameworks that recognized it as a national priority in South Africa. And so those are my 3 key points. But before I hand back to you, Professor Alistair, I want to come through from a social science perspective. And what is important to recognize here is that policy commitments don't always automatically translate into meaningful access to services. So health systems often measure coverage. So do we have commodities in service? But what ultimately matters is whether people or your end users and beneficiaries are able to access that benefit and benefit from these services in their everyday lives. So thank you very much. I'll hand back to you.
Thank you, Dr. Esak. That was great. The third question is addressed to our panelists, Olabukunola Baki Williams. And your question for this afternoon is, civil society plays a critical role in advocacy, in elevating community voices, in strengthening accountability in health system reforms. From your perspective, Baki, how can civil society ensure that comprehensive SRHR services, particularly for marginalized women, children, and adolescents, and refugees and survivors of gender-based violence, are meaningfully included and protected within national UHC benefit packages, as well as financing mechanisms? You've got 5 minutes for your response, Olabukunola. Thank you.
Thank you. And thank you for not butchering my name. Well done. Good afternoon, good evening, everyone. I am, coming in from Uganda, from rainy Uganda, and I'm glad to be part of this conversation. Just to build on what Dr. Zainab said, because she's built it up very significantly. I think we take it for granted that SRHR is still part of the conversation within universal health coverage. I remember in 2019, during the political summit, on UHC, in which we had to fight to ensure there was a paragraph on SRHR. And then in 2023, realizing that we have weaker language. And I think it's important for us to have that conversation because national priorities are often defined by these global political commitments that are made by our government. And because sexual and reproductive health and rights has become politically contested, we are seeing that right now with the Trump administration. We are seeing that some African governments are not even willing to have conversations around SRHR. They may be willing to have conversations around sexual and reproductive health, but don't want to talk about rights. And we know that rights are what leads to health. And it's quite important. And I think civil society, we need to continue to have that conversation to ensure that SRHR remains on the agenda. Because what we're seeing is that SRHR is slowly being removed from the agenda. We're hearing more conversations around family planning. We're hearing more conversations around maternal health, but not on that complete package that Jyoti showed earlier. We're seeing the removal of it. Well, in many ways, even the demonization of these conversations, we're seeing increasingly what we're calling the anti-rights movement, which is a political mobilization globally with large resources, pushing back and saying African governments should not focus on SRHR. So increasingly, we're seeing a direct contradiction between the conversation around right to development and sexual and reproductive health and rights. And we keep seeing that happening. And so we even have the standard declaration on primary healthcare that doesn't specifically mention rights, especially when it talks about sexual and reproductive health and rights. So feminist movements, SRHR movements have been fighting for this. And I think this is something that governments need to recognize, that it's important for us to not lose that conversation. around sexual and reproductive health and rights. I think what we've seen in countries like Uganda and Nigeria is the generation of evidence, which is where I've worked. Because when we're talking about essential, it means we want it in the basic package of care. It means we want to see that when we go to facilities that it's available. And often when we say and have these conversations with governments, they ask us, where is your evidence? And that's something civil society has been doing, continues to do. We're doing it through research. More recently in the program, we're doing it through scorecard. Africa is a young continent. The median age is about 20 years old. And so when we're planning programs, we're not thinking of sexual reproductive health and rights as it deals with adolescents. We're often thinking of middle-aged, those who are married. We're not thinking of unmarried adolescents. We're not thinking of refugees. We're not thinking of sexual and gender minorities. We're not thinking of youth with disabilities. And so for us, one of the things that has worked is the use of scorecards, where we actually go directly to facilities and say, this is supposed to exist, as was mentioned, that it's not just policy. This is supposed to exist. It does not exist. How can we have a conversation at the facility level, at the district level? Because all politics, as you know, is local. And being able to have those conversations with facilities, we've been able to see changes from local districts being willing to increase their budget, either on HIV or on SRHR, or health workers being able to say, how can we work together? Or young people being included in joint monitoring committees to be able to have a conversation, because we know that that burden, if not done by health workers, often fall on women and young people in their communities. We do the care work. And the out-of-pocket spending is limited to us in particular. One of the things we also realize is that a lot of civil society organizations are not in the budget conversations. We leave that to bigger INGOs, international organizations, or we leave it to those who understand the economics. One of the things we've had to do at Akina Mamawa Africa is work directly with community-based organization, women-led organization, young women-led ones, disability rights organizations, LGBTQI organizations, especially LBQ, lesbian, bisexual, and queer women, to say, look, we know that often your communities are criminalized, like sex workers. We often know we're seeing the introduction of anti-LGBTQI laws, but we have to make sure that we're part of the conversations. You have been running drop-in centers. You're at the heart of ensuring that your communities get access, even when governments don't want to have conversations with you. We're seeing new conversations around integration. What does that mean for the drop-in centers? And so we've had to help organizations and have conversations about, we need to understand the global financial architecture that determines how our governments determine their budgets, but also to be able to understand those budgets to say, what are we holding governments accountable to? But we also find out that local officials also don't know how the budget systems work. And so we've had to work with local officials to say, actually, this is what we're discussing in Parliament. This is how we can have the conversations. And we've been able to see some transformations, an increase in refugee settlements in Terego in Uganda, for example, for that to happen and to be able to have that kind of conversation. And we've even seen young people who decided to run for office in their local communities because they decided that they want to be part of that conversation in particular. And another thing that we've had to realize is the need to sustain this work in particular, because as less money comes into the sector, as we see more compliance issues coming up with civil society organizations, we've realized that it's quite important for us to find other ways to have this conversation. And so as the space closes for SRHR conversations, we've had to move that conversation into the financing conversation to ensure that we're not left behind and to ensure that the furthest behind, as we say in SDG language, is actually reached. So let me stop there. Thank you.
Thank you very much, Ola. Really appreciate your perspectives. We're now going to turn our focus back to country implementation lessons, and I'm going to start with Ms. Rachel. Ms. Rachel, in 4 minutes, can you paint a picture of access to essential SRH commodities often remains vulnerable to fragmented procurement, fluctuating demand, and supply disruptions? What role can regional pooled procurement, coordinated demand forecasting, and broader market shaping efforts play in strengthening supply security and in improving the affordability of SRH technologies as countries advance UHC? You have 4 minutes, Ms. Rachel.
Thank you, Prof, for that question, and a very important question because we're looking at ensuring quality assured commodities for SRH, and then also looking at the funding landscape and being able to bring in enough commodities to meet our domestic needs. So pooled procurement comes in as a way of reducing the cost and also assuring quality in terms of having a value-based procurement. We are able to, having that aggregated demand, be able to benefit from issues of scale and be able to get lower prices. So we see that happening even as the region, as I spoke to before, as SADC comes together and starts putting together this pooled procurement mechanisms where countries are able to share demand information. And this also speaks to the forecasting, where if countries have had challenges, there are new products that are coming in on the market that we do not have enough information for, and you have a country in the region that has already done some implementation, talked about the challenges, talked about the uptake rate. Those can be factored in. Country does its own demand forecasting, so it allows the demand forecasting to be better because we're sharing information, being able to compare data across the nations, and then coming together as a region to bargain, because we are more powerful together than separate. So where a bloc or Africa as a region comes together and is able to demand and bargain and negotiate, we are able to achieve better prices and better access because we're representing a bigger number of the population and a bigger market. So this is where pooled procurement comes in, and even the data sharing, even where you have not done the pooled procurement, even as a nation being able to, for example, know the prices at which certain commodities are being procured, maybe in South Africa, Botswana, if we're being charged exorbitant prices, there's more information we're able to negotiate better. So just that data sharing and pulling together and having a collective voice so that we are able to get better prices. I think those are the benefits that the pooled procurement mechanism brings in. And even as far as strategic partnerships, having even MOUs with these UN agencies that also do the pooled procurement. So we have the region moving together, and then we also have these strategic partnerships that we can work with together so that we get value and quality, and then at more affordable prices.
Thank you very much, Ms. Rachel, and thank you for pushing through despite connectivity challenges. We appreciate it. Professor Chen, I'm going to turn the same question to you. What role can regional pool procurement, coordinated demand forecasting, and broader market shaping efforts play in strengthening supply security and improving the affordability of SRA's technologies as countries advance UHC? You have 4 minutes, Prof. Chen. Thank you.
Okay, thank you very much. I think that for those kind of public health services and those kind of poor procurement is very important. So I already mentioned, and for those kind of a generic drug and also those medical devices, and we use quite a lot. And some, and that's actually we have the national level, that's a group purchasing. So that's the volume is quite big. And so sometimes and the purchasing power is significant and over those kind of a supplier. So the government can get very good and that's price, and that's I think very important, reducing the price. And okay, so just improve the equity of services. And for the SRHR and for example, and also for those kind of Down syndrome screening, and some provinces you use genetic, and testing is more valid and also specific, and so that's a good technology. The challenge is the price is very high. So I think those kind of provincial and health bureau and just just have those kind of poor group of pooling and as procurement and reducing those kind of price and try to give those kind of genetic testing and for all those kind of people and with that's SRHR person. So I think we have a lot of cases over there, but I think, and sometimes we also use the cost effectiveness and also budget impact analysis and try to just inform the policymaker and how to select those different kind of technology. And the other one I think is also very important. The quality of those kind of procurement and products are also very important. We also have those kind of mechanism and monitor those quality and also that's at the reasonable prices. So I think in China and medical insurance and others mechanism work together and try to achieve the goal. And the other one, I think, and have some question about the doctor at the village and the clinics. And I think in China, most of the right now rural and the village clinics all and run by the doctor, those kind of registered doctor. And so they have some prescribed and to those kind of normal and diseases and this treatment, but also including the basic maternal and child and services, maybe and also assisted by the nurse, and that's the village and the clinics. So I think that's all this time. Thank you.
Thanks very much, Prof. Chen. While I have you, can I just double click on the village clinic model? Are these services provided by medical doctors or nurses or community health workers? Please just clarify for us.
Yes. I think mainly is by the doctor and at the village and that's clinics and so, but this and the village and the clinics and maybe have a couple of that's the health and provider and one and registered doctor, one nurses.
Okay, thanks, Prof. Chen. I think we've lost you there. Thanks for that. Ms. Rachel, if I can just turn back to you quickly, just on some of the challenges around SADC regional pooling procurement. Can you share some ideas perhaps on bureaucracies, on timing and duration of procurement, if you will?
Okay, so for the SADC pooled procurement, this is where we are at the stage where we're establishing the SADC pooled procurement services. And we're in the beginning stages where the countries are now looking at how do we share the data and also trying to do the group contracting. Group contracting was looked at as a model because they noted that even across the region, we have different laws. So they typically, when you're for certain pooled procurement mechanisms, if you're using like the UN agencies, they require advance payment into the pooled procurement, and then they proceed to do the procurement. But certain laws in different countries may not allow that advance payment. So you find that different countries have different stages, and they have different specific laws, which are a bit difficult to may take a bit of time to align so that the pooled procurement works well. So the beginning step was also just trying to pilot the group contracting, where you can still bargain as a collective, but then each individual country within their law, after the competitive prices have been achieved, can now enter into contracts in that instance. So that's why group contracting came in. But as a service as a whole, we're yet to have the institution that will be conducting those pooled procurement mechanisms. But the countries, what has happened is the countries have undertaken assessments and looked at data sharing, provided their priority products, including SRH commodities, as priorities for good procurement. And then we're looking to the next stage when we actually have established that subsidiary. But right now, what is happening is the piloting around group contracting, because as you've rightly put it, there are certain bureaucracies in terms of changing procurement laws that would allow such a thing to happen smoothly. But that is part of the assessment, working towards seeing how each country navigates around that, but then trying to see what benefit can we still get even at the stage before we reach there. And the data sharing is quite an important aspect, because even before you have that procurement, you have information that you can use to make decisions and give you more power as you negotiate. Thank you.
Thanks very much. Thanks, Ms. Rachel. And we're happy that your Wi-Fi is holding up. So I'm going to summarize very quickly what the panelists shared with us before we open up to a Q&A. But really, thank you for those great insights, everybody. We've heard first how health finance and design, whether through national health insurance or other pooled arrangements, can be used to strengthen risk pooling and cross-subsidization, particularly to protect women, children, and adolescents. We've also heard that the case for comprehensive SRHR within UHC is not only a public health imperative, but a compelling economic and political investment in human capital, as well as long-term development. From civil society, we've been reminded that reforms succeed only when they are grounded in community realities and backed by strong accountability, ensuring that those who are most marginalized are not left in benefit package design or indeed in implementation. And from country examples like Zambia and China, we've seen the importance of robust supply chains, pooled procurement, and better use of data to secure affordable, reliable access to essential SRH commodities as UHC advances. So that's just a flyover of what the panelists shared with us today, but I'm now excited to turn the attention to the audience and to invite you to ask us a couple of questions. So those of you that are joining online, please use the Q&A function to submit your questions. And for colleagues here in the room, please raise your hand and we'll direct a microphone to you. If your question could be clear, succinct, and also suggest which panelists you would like to respond to your question. Thanks very much. The first question from Dr. Lwazi, please can we get the microphone to her? Thank you very much. Am I audible?
Sorry. Thanks so much to all of the speakers for a very, very insightful session. I wanted to ask a question to Dr. Chen.
Prof. Chen.
Professor Chen. Prof, here in South Africa, you might be aware that we are trying to implement the national health insurance. But one of the great tensions that we are seeing as we are trying to bring the government and the private sector together is the tension around multi-payer versus single-payer models. And I've heard some of my colleagues say that China has a multi-payer model, but they're reconsidering it and they want to move to a single-payer model. So first, I want to ask, is that true? And secondly, also, I think the numbers do speak for themselves. You did show us the metrics by which you are measuring the success of equitable access. But I would like to just get China's perspective on that particular tension, how you managed it, and your views on whether the multi-payer system is actually working for China and why. Thank you.
Prof. Chen, that's for you. I hope you got the question. Prof. Chen, are you with us? The question for Prof. Chen was, is China considering moving from a single payer to multi-payer, from multi-payer to single payer approach? Have we lost Prof. Chen? Okay, so we will bank that question for Prof. Chen. Can we move on to the next question? Anybody else has a question in the room, online? So while we're thinking about that question, perhaps I can ask Dr. Isak a question. Dr. Isak, you raised the importance of not just providing access to services through UHC, but ensuring that people can access and use them. Can you share with us any strategies that are being used to address barriers to care and uptake?
Sure, I was furiously typing the answer in the chat, but thank you for giving me the opportunity to speak. I think I can speak from a social science perspective, and then that just speaks to why we need to understand lived perspectives and practices and perceptions of communities. Sometimes barriers exist not at a structural level, so at the health system level, but also at an individual or community level. So inability to access the clinic because of floods and roads being washed away, or no access to finances, for example. So that's the first point. The second is we need to not just make sure there's commodities, but make sure that services delivered are quality services that are provided and that they are acceptable to the people who they are being provided to. And then thirdly, a lot of the work I do is trying to understand how to decentralize some of these SRH services and to take them closer to communities, particularly those who have limited access to care and where care services or clinics are not in close proximity. So exploring community-based delivery options of various sexual and reproductive health services is one of the other strategies to help to address this gap. Thank you so much, Prof.
Are there any other questions, perhaps? There's a question from Busani in the room.
We cannot hear. For those in the room, we cannot hear Professor Busani.
Until maybe next sketch, then everybody else will add and it will be on the agenda. Is this a correct observation, or SRH remains on top of the agenda of everybody in the region, even outside of the periods of pandemics?
Thanks very much for that input, Busani. Any of the panelists would like to respond, to add or build on that? We've got a hand from Jyoti. Jyoti, do you want to come in?
Thanks, Professor Alistair, but I could not hear the question. But just I wanted to add, since we have a bit of time, wanted to just add three quick things. The first thing, which Dr. Jainab and also Dr. William from Uganda pointed out. So relatively in the region, I think we have done reasonably well in including many elements of SRHR in primary essential healthcare service packages, but they are hugely ambitious, and then most countries are struggling to fund those packages. And then fair enough, it's the aspiration of the government to now, largely because of the financial constraint, people are trying to look at reduced packages which the government can guarantee, almost from the aspiration to some kind of a contractual arrangement where you can put together a financing and an arrangement there. And that's something. And then therefore any generic conversation around what needs to be their advocacy around it may not be that useful for translating those commitments into services. For that, we need to know for every country which services are included, which are not included, and why something is not included, and any argument around that. So the generic argument, I think we have done an amazing job. Everybody is well aware of the generic argument, the benefits and everything. Now, I think the next level of improvements will come from specifics. And then the offer here is that we have developed a tool. We took the WHO compendium and mapped it across the 9 elements across the life course. And anybody can use that tool, look at the service package and then see what is missing and why it is missing. And then therefore, then progressively you can look at the mobility and the suffering and say, these are the services which are extremely important for this particular segment, which are missing. And that's where it needs to go. So we are still engaged, a lot of us, in generic conversation, I think, which was really important for last 30, 35 years, but now the specifics. The second one is quite interesting. Again, we need to pay a bit of attention because something is included. Many SRHR services are included in this ambitious primary healthcare benefit package. Therefore, in many countries, there is an argument that we don't have to include it in the USC benefit package. So we need to think about it. What does it mean? So those are ambitious, underfunded, not available. And because they are included there, you don't include in something which is better funded at this point of time. So we need to think about it, how it unfolds. And lastly, I think it was Dr. William who pointed out, even in things which are included, specific groups are not mentioned there, whether it's young people, refugees, survivors, and sex workers, again, need to be paid. So 3 very, very practical things, but everything requires now specific. So generic brief perhaps serves its purpose. And now is the time to look at the context, look at the packages, look at the financing arrangement, look at the fiscal space, and do something about it. Over to you.
Thanks very much, Yoti. Can I bring in Dr. Katleho?
Thank you very much, Prof. We couldn't pick up what Prof. Busani was saying, and also my input is also not directed to the question he asked. I just wanted to add an additional perspective to Dr. Esak's input on the question that was directed to her in terms of some of these barriers. I think the trap that I often see is that when you look at the Sustainable Development Goals, we often want to discuss them singularly, and we forget how interconnected they are, almost all of them. And it would be counterintuitive for us to think that we could just focus on UHC and sexual reproductive health and not consider what other things. And I want to put forward an example of a challenge that we face in South Africa and possibly in the region as well, around teenage pregnancies. Often this is counted as a health statistic rather than addressing it as a crime that it is. One of the SDGs talks to peace, justice, and strong institutions. Now, for as long as you don't deal with the other elements that have an impact on healthcare, we will continue to see a lot of investment going into these initiatives and not achieving the right sort of outcomes. Whether it's infectious diseases, and we're not paying enough attention to water and sanitation, or even issues of poverty, gender equity, etc. So while we are focused on one specific aspect of delivering universal health coverage, we should not turn a blind eye to all the other elements that are contained in the other SDGs. Thank you, Prof.
Thank you very much for that, Dr. Muturi. We really appreciate it. Folks, I think just in the interest of time, I'm going to move us along to the Mentimeter. You know the drill. We'd like you to to ask us some questions and just put your comments in the Mentimeter. So the questions will come up. So if you could just scan the QR code and just follow the link as per usual. So we'll spend about 2 minutes per question and we'll move through the questions. Can you see the questions? Is it clear? Is everybody connected on Mentimeter? Yeah? Menti.com. If you can't get through to the barcode, the URL is menti.com and you'll get a code to join. So that question is, in your country's context, which financing opportunity is most achievable in the near term to advance domestically financed SRH within UHC? Thank you for your answers. Leading the pack is reprioritization within existing public health expenditure, followed by pooling or transitioning donor-funded SRH services into public financing mechanisms. And then third is expansion of fiscal space for health. I think some folks are still answering. Okay, shall we move on to the next question? So the third question is based on the China case study presented by Prof. Chen, which approaches could be applied in your country to support domestic financing of SRH within UHC? So based on the China case study presented, which approaches could be applied in your country to support domestic financing of SRH within UHC? Okay, digital health systems to monitor SRH coverage, quality, and equity seems to be leading the pack, followed by strategic purchasing of maternal and reproductive health services. And then we've got using HTA to privatize SRH services for inclusion in UHC benefit packages. I think we're good to go to the next question. So the fourth poll question is, which condition is most critical to integrating SRH into domestically financed UH systems in your country's context? Which condition is most critical for integrating SRH into domestically financed UHC systems in your country's context? Okay, so the leading response there is government leadership and political commitment, cross-sector coordination, alignment with domestic resource mobilization strategies. I think we've got time for one more question and then we'll close the Mentimeter. So the fifth question is, what is the biggest barrier to integrating SRH into domestically financed UHC benefit packages in your country's setting? What's the biggest barrier to integrating SRH into domestically financed UHC benefit packages in your country's setting? So low prioritization of SRH in national financing decisions, fragmented policy or governance structures, limited fiscal space for health, weak cost utilization or expenditure data. Great stuff. Thanks, colleagues. That was great. Lovely insights. That should help us going forward. The sixth question is, which partnership is most critical for advancing domestically financed SRH within UHC benefit packages in your country? I think we've just covered this one, so we're good. Thanks very much for the Mentimeter participation. Much appreciated. So all these responses will go a long way in helping us package some approaches going forward. So just some key highlights coming out of this: sustaining integrated SRH, priority for SRH, advocacy, experience sharing is key. SRHR continues to gain. Civil society engagement is important. Government commitment is important. So thank you very, very much for that. I'm now going to turn our attention to segment 8, which is closing remarks by Rajat Khoshla. Rajat represents PMNCH. Thanks, Rajat.
Thank you, Prof. And it's great to be with you all today. And I have to start by saying what a remarkable conversation. And thanks to you, Alistair, for such a wonderful moderation. Colleagues, as multiple speakers and our dear moderator has highlighted as well, there are a few takeaways that I have been jotting down at the side of this 2-hour conversations that we are concluding now. The first is indeed, sexual and reproductive health and rights are not merely a component of universal health coverage. They are at the very core. However, as multiple speakers have highlighted in the discussion today, we are at a dangerous crossroads. We are witnessing a dual crisis, a sharp erosion of political will and a steep decline in financial support. And if the current trends persist, the ODA for health in 2027 is likely to fall below the 2020 levels. and that will be catastrophic. And you did hear some examples in terms of abrupt disruptions in pipelines, in funding flows, and the impact that it is likely to have. Across the globe, and specifically within the African continent, we are seeing laws regressing as anti-rights rhetoric is gaining momentum. And this has a significant impact in terms of our ability to deliver on the plethora of SRH services and packages that we have talked about. Such regressive policies, including the expanded global gag rule, have an unprecedented impact on SRHR services. Our own survey in October last year showed about 20% programs were already shutting down on SRH issues. The broad scope of this policy now, which has been reinstated and expanded in January this year, including new restrictions linked to diversity, equity, and inclusion, is going to reduce access to essential, high quality, and life-saving sexual and reproductive health services. And thank you, really, Jyoti, for that remarkable presentation and the different packages and details that you talked about. But the human cost of these cuts is going to be staggering. We are estimating that between 2025 and 2040, it is projected that there will be an additional 510,000 maternal deaths and 500,000 deaths resulting from loss of family planning services, and an estimated 40 to 55 million additional unplanned pregnancies and 12 to 16 million unsafe abortions are projected. These are not PMNCH figures. These are figures coming from UN agencies and data monitoring outlets as well. This is not a distant threat, therefore. The impact is being felt now. In 2025 itself, the dramatic cuts, according to UNFPA, funding forced the closure of nearly over 1,000 health facilities and 250 safe spaces, I should say, for women and girls globally. The reports indicate that 9.7 million worth of contraceptives were slated for incineration, 3/4 of which were destined for Africa. Colleagues, I can go on and on about the devastation that is happening more broadly within global health, but more specifically on issues related to sexual and reproductive health and rights and their direct impact on the ability to make services available on the continent in Africa, but in other regions of the world as well. So now more than ever, the focus on expansion of UHC schemes is crucial. It is critical to integrate sexual and reproductive health and rights into these schemes to ensure that the unique needs of women and other marginalized groups are not sidelined by broader economic and political issues. And this is one of our biggest challenges right now. Because of the funding pressures and the stresses the system is facing, there is a push to focus on the core of global health. And surprisingly, the core of global health does not seem to include women and children's health, let alone sexual and reproductive health and rights. Colleagues, as multiple speakers have spoken, SRHR is not just a matter of right, it is also an engine of economic growth. By ensuring access to comprehensive care, we empower women to transition from vulnerability to economic agency and dignity. In the current geopolitical and socioeconomic context, today's discussion marks an important opportunity for us to visualize and outline how we must align the health priorities with the urgent needs of resilience, rights-based healthcare that leave no one behind. And you heard some remarkable examples on that from countries like Zambia, China, and others that took the floor today to detail the agenda. As they outline, finding solution to these compounding issues require an all-hands-on-deck approach to ensure legal protections, service integration, countermeasures for misinformation, and crisis-resilient SRHR service delivery models, including engagement with parliamentarians who can help articulate the virtuous cycle of SRHR and gender equality. Colleagues, it is clear also that global aid is no longer the answer. To achieve true health sovereignty, African nations are leading the way and prioritizing domestic resource mobilization. And we heard some very remarkable examples today. By integrating SRHR into these national health insurance schemes, we can ensure that every woman's right to health is funded by stable internal revenues rather than volatile external grants. Sustainable UHC requires ongoing efforts towards Maputo Plan of Action for achieving universal access, to comprehensive sexual and reproductive health and rights across the continent. And finally, colleagues, the inclusion of SRHR in UHC is meaningless without robust accountability mechanisms and harmonized resource tracking. We must institutionalize social accountability, empowering civil society and youth advocates to act as watchdogs of SRHR spending. Only through transparent, tracked, and protected budget lines can we ensure that health sovereignty leads to actual health outcome. So as we get ready for the United Nations high-level meeting in 2027 for UHC, let's make sure that these issues are at the center of the agenda and not at periphery. Back to you.
Thank you very much for that wonderful conclusion, Rajat. We really appreciate it. Colleagues, we've come to the end of the road today, and I really want to thank you for your participation. I want to thank you for all the contributions from all the speakers. It's been wonderful. The insights are great, and they'll prove to be very useful going forward. I also just want to conclude by just highlighting the following. Today has underlined that sexual and reproductive health is not a peripheral issue, but a core test of whether universal health coverage indeed delivers on its promise of equity, financial protection, and strong primary health care. We've heard concrete lessons from Zambia and China on integrating SRH into benefit packages and strategic purchasing. We've reflected on policy and financing choices that can protect SRH even when fiscal space is tight. And we explored how better data, supply chains, and accountability can indeed close the gap between commitment and delivery. Allow me to leave you with the following 3 core messages from today. The first one is, it is possible to protect and prioritize SRH within UHC reforms, even in constrained fiscal contexts, when it is treated as essential rather than optional. The second takeaway is evidence-informed and rights-focused approaches are vital if we're serious about reaching those who are currently left behind. And the last takeaway is sustained collaborative action across governments, parliaments, civil society, professional bodies, development partners, and communities is the only way that these principles can translate into lasting impact for women, children, and adolescents. Thank you once again for your time, ladies and gentlemen, your insights, your commitment, your passion, and your energy in contributing to these discussions. We look forward to working with you again to carry today's discussions forward and to turn these insights into concrete action in your respective countries and institutions. And with that, I'd like to invite us to give all the speakers and panelists a round of applause, please. Thank you very much. Session is ended.